we're here to just have a brief discussion, again doing something similar to what we've done, taking varying concepts and presenting them in a more cohesive fashion. So kind of sewing these things together. So something that you may be looking at from an external point of view and trying to figure out how you might figure that out. We take the concepts that we've spoken about in the past and identify how they're showing up in what I'm doing. Here, what we're going to do is take a look at the pectoral musculature with a patient in supine. Now, based on camera angle, not all of this will be perfect, and that's fine, but you'll get the idea, and I will kind of show what my hand's doing. So one of the things we talk about when we're working on soft tissue is, very generally speaking, historically within the osteopathic profession, people work perpendicular to fiber direction. With the pectoral musculature, you have varying fiber direction, so this isn't always a perfect thing, but you get some ideas. One of the places that it seems very useful, clinically speaking or experientially speaking, to work on the pectoral muscles is essentially as they blend in towards the shoulder, more or less as the roof of the axilla or the roof of the armpit. To do that, many people, or in many situations, what you'll see, and I'll show it on myself because it won't be as clear on the patient, but people will kind of pull the arm back behind the body to put a lot of stretch on all of the pectoral fibers, more or less, so major and minor, as well as multiple directions, and then you can kind of move the arm around as you see fit. What we've spoken about before with respect to working on soft tissue is not simply working perpendicular to fiber direction, but often lengthening it makes it a little bit harder for a hands-on practitioner to deal with. So what we'll often do is try to keep the muscle itself, the muscle belly, with lower amounts of tension in it. So we can talk here about leverage and contact as control, and also short and long leverage. So I can expose the lateral portion of the pectoral musculature. Right, so here it's all kind of hidden, it's all kind of closed. If the patient's arm is here, I'm going to have a hard time. Also, based on angle, it's very likely that you can make somebody uncomfortable because of where the majority of your hand will land. So what we want to do is we expose, right? So we expose the tissue somewhat, and then we pin the patient's arm to our body. So contact is control and control is safety. So once I pin them to my body, I have contact with my body, I have contact with my arm so that their arm doesn't fall, and I can wrap around, right? So I have lots of contact, lots of control. I have my long lever, so the arm as a unit becomes my long lever to approach the pectoral tissue. Then I have my short lever, so again, that lateral tissue, that tissue that forms more or less the roof of the axilla. I can take a broad hand, use kind of the heel of my hand, place it here, right? So I can basically have a relational motion situation here where I can push the tissue, I can hold the tissue, so push the tissue and keep the arm still, so the tissue moves, the arm stays still. I can keep the tissue still, move the arm. So the net result of that in a relational motion sense is that we get bowing of this portion of the tissue. So this is one way to do that, okay? So we've got long lever, short lever, aka mixed leverage. We've got relational motion, either the arm or the tissue itself moves and the other one stays still. We have contact as control. All of these things kind of going together to help guide the discussion about what we can do here. Now, if we talk about hand postures, as I said, we can use the heel of our hand here. We can kind of bow the pectoral tissue. There's some other things that we can do that are of interest. So instead of just bowing it, right, so oftentimes you will see practitioners pull the arm away and they'll get into that lateral portion or the roof of the axilla as far as the pectoral tissues are concerned. But what we can also do is kind of have a bow, say, towards the ceiling or towards the floor. We can move the tissue in that direction as well. So if we take a hand like this, or kind of more of like a yoke hold, more or less, we can wrap around the tissue. So my thumb can kind of go into the axilla and bend in this fashion so I have more contact with the posterior portion of the pectoral tissue, and I can lift and drop. I can lift the tissue and drop the tissue in a relative kind of, as I said, to the ceiling or to the floor manner. So I can do that. So now I have more planes of motion with the tissue itself. So essentially I have towards the patient, away from the patient, or really more or less towards the patient. I can push that way. Now I can add in kind of a lift or a drop wherever I feel what I'm looking to feel with the tissue. If I want to go indirect, it's because there is a pain response and I want to soften the tissue. If there is no pain response on motion into a restrictive barrier, I can go direct, aka into the restrictive barrier. So I can make that choice. I've got a lift and a drop, right? Again, we're looking at combining concepts. Now I've got my relational motion, so I lift, I can push, and I can pull. So I've got a bunch of different things happening at once, all off of one hold. So the holds are still central. Contact is control, control is safety. Long lever, short lever, mixed leverage. Another way to utilize that short lever is in my hold. All of this comes together to allow me to do a lot of varying things in one place, right? So I have a lot more options with this pectoral tissue. Again, we talk about working generally perpendicular to fiber direction, and we talk about, with soft tissue, trying to keep the muscle belly short if possible to work on them. It allows us to mobilize them a little bit more respectfully and with a greater ease.